Good morning, everyone. This is Dr. Randy, and we will be beginning our actual um, clinical pharmacy and pharmacotherapy lectures. So, prior to this presentation, we have already learned the clinical record, which is a summary of the important detail in the story of the patient's illness and the physical examination findings. So right now, we will be dealing with drug interactions and adverse effects. This is our second lesson, the penultimate lesson or second to the last before we have our prelim exam. Let's have first the following definitions in mind. An adverse drug event is any unwanted occurrence after exposure to a drug that is not necessarily caused by the drug. So, think of it simply as any event that you do not expect or you do not want, for that matter, after giving a drug to a patient. And an important caveat of this is the definition or the phrase not necessarily caused by the drug. So, ibig sabihin yan, pwede na there is an adverse drug event noted after taking a drug that is not caused by the drug. For example, an adverse drug event such as dying 3 hours after being vaccinated with the COVID vaccine can be noted as an adverse drug event even if the mean of dying would be traumatic vehicular accident. No? So, ulitin ko, nag-vaccinate ka ng isang pasyente and then 3 hours later, namatay yung pasyente dahil nasagasaan siya. Even if ang manner of dying of the patient ay ang pagkakasagasa sa kanya, that will still be noted as an adverse drug event. Okay? So, next, let's contrast that with an adverse drug reaction. An adverse drug reaction is any undesirable effect of a drug beyond its anticipated therapeutic effects occurring during clinical use. For example, if mayroon kang pasyente na umiinom ng let's say Benadryl for an allergic process. Remember that Benadryl is an antihistamine, diphenhydramine. So you take it to treat the itchiness of the skin, but after 2 hours of taking the Benadryl tablet, you experience or the patient experienced drowsiness and went to bed. So the drowsiness there is an undesirable effect that is beyond the anticipated therapeutic effect of anti-allergy. So that response there is an adverse drug reaction. However, an adverse drug reaction can be explained by pharmacological concepts. In our example, doon sa pag-take ng diphenhydramine, the pharmacological principle is the inhibition of histamine receptors in the reticular activating system, portion of the brain that causes the brain to be awake. So, an adverse drug reaction can be explained in that manner. Okay? So next, let's define what a medication process is. A medication process is the 5 steps in medication management. So it involves prescribing by the doctor or a clinical pharmacist, or in the US, they have now a profession called the nurse practitioner. So he or she is a nurse but can prescribe simple medications. You have dispensing, we do this one. Administering, done by the nurse, some by the clinical or immunizing pharmacist. Monitoring, and systems control. So these are the 5 steps in the medication process: prescription, dispensing, administering, monitoring, and systems control. Now, this is usually done by the clinical pharmacist or the resident physician or the physician. The medication use review. These are interventions and plans aimed at both the administering and monitoring of the stages of the medication process. What is your goal in the medication use review? To check the patient's need for and understanding of their medicines. So, take notice of these 2 words, plan and intervention. So, what does that entail? You can have a patient, a high-risk patient, for example, an elderly patient with a lot of medications. Just by knowing that your patient is at high risk for adverse drug events, you will then utilize a medication use review. You plan to do a review so that you will be able to detect any potential rectifiable point in the patient's medication use that can be improved so that an adverse drug event does not occur. So, ulitin ko ha. For example, meron kang isang pasyente, matanda, sobrang daming gamot na iniinom. By being aware that there is such a patient, you will deliberately perform a medication use review with the goal of finding out kung meron bang mga medicines na hindi na kailangan ng pasyenteng ito or predictable drug interactions. So, that is the planning of the medication use review. However, there can be interventions. What does that mean? You have done your medication use review and you have found out any adverse drug event or drug interaction. After finding out of such things, you will then create an intervention to treat the effects of the interaction or to manage the adverse drug event. For example, sa ating pasyente kanina na nag-take ng diphenhydramine for the treatment of allergy and then inantok, what can be an intervention? Educating the patient that he or she should not use or should not operate any heavy machinery or drive. That in itself is an intervention. Okay. Next, what is a type A ADR? A type A adverse drug reaction is related to the dose and the pharmacological effect and are potentially preventable. You can predict a type A ADR. For example, doon sa ating ginamit kanina, diphenhydramine for the treatment of allergy, producing drowsiness. That is an anticipated or predictable response. Why? Because we already know that histamine is an important neurotransmitter for wakefulness. Para magising ka, you need histamine in the reticular activating system of the brainstem. So, kung magbibigay ka ng antihistamine, in our example, diphenhydramine, you will then anticipate that it will block the effect of histamine in RAAS, reticular ascending activating system, and cause drowsiness. So that is an example of a type A ADR because the reaction is related to the pharmacological effect of the drug. Another type would be type B. Type B is classically described as idiosyncratic. So idiosyncratic reactions are not dose-dependent. So kahit konti lang yung ibigay mo, there will already be a reaction. Idiosyncratic reactions are unpredictable. So that means you will not know if it will happen. And because it is unpredictable, it is not preventable. So the idiosyncrasies, which are your type B adverse drug reactions, are genetically encoded. So what does that entail? There will be groups of patients who will have the reaction, and there will be groups of patients who will not have the idiosyncratic reaction. Why? Because there are differences in the gene that entail the reaction. Those who have the genetic predisposition to the reaction will experience it. For example, this is used in chemotherapy. So right now, this definition, not predictable and not preventable, is already being changed because we can now look at the gene and determine if you have a high chance of reacting poorly to the medicine. That is why the oncologist will steer away from the medicine if, for example, the patient is found to have an increased expression of the gene for the enzyme, example, producing the adverse drug reaction by producing the metabolite. Okay? Okay. So let's now encounter some of the common drug interactions. For us in pharmacy, we dichotomize the drug interactions, the classic drug interactions, into inducers and inhibitors. Inducers are drugs that cause an increase in the rate, bilis, and extent, the totality of biotransformation or metabolism of other substances by stimulating the body's enzymes. So these enzymes, for example, are the CYP, cytochrome P450 enzyme system found in the microsomes or vesicles inside the cell, in particular, the hepatocyte or liver cell. So, anong ginagawa ng isang inducer? It will cause the enzymes to act more effectively and to act more rapidly. So, because the enzymes are in a state of being turned on, the enzymes will quickly metabolize the drug and therefore decrease the effect of the drug, or if you have a pro-drug, increase the toxicity or effect of the drug. For example, if you have the drug enalapril. Enalapril is a prodrug. It is an ACE inhibitor. However, the active form is enalaprilat. So if you have an inducer being taken by the patient who is also taking enalaprilat, enalapril, sorry, the patient will have more rapid conversion of enalapril to enalaprilat. And you will expect that the patient might have, in those particular instances that he or she is taking an inducer, the patient might have episodes of hypotension. Kasi mabilis na nako-convert yung enalapril to enalaprilat in the presence of an inducer. Kung walang inducer, the patient is normotensive. But in the presence of the inducer, the patient will become not all the time hypotensive. Okay. Next, inhibitors. Inhibitors, kabaliktaran. They will decrease the rate and extent of metabolism of a drug or other drugs by binding to and inhibiting the enzyme. So, didikit sila sa enzyme and that will inhibit the enzyme, or they will go into the genes, affect the proteins that regulate the genes, and therefore decrease the production of the enzyme through the central dogma. So what is the end effect? The enzyme activity decreases. And so, for example, if you have a drug that is normally being metabolized at a particular rate, giving the inhibitor will decrease the metabolism of the drug and allow the drug to accumulate in the body, reaching toxic levels. Okay, so that is an example of how an inhibitor works. So let's just notice or know these common inducers. I am not fond of mnemonics, but this is one of the mnemonics that you can use. Carbamazepine, an anti-seizure medication. Rifampicin, a drug that you use for bacterial infections, including tuberculosis. Chronic alcohol intake or alcoholism. So, be wary of this ha. If matagal na tinitake yung alcohol, no, chronic alcoholic, they are in a state of enzyme induction. Phenytoin, which is also an anti-seizure medication. Griseofulvin, which is an oral antifungal. Phenobarbital, which is a CNS depressant, can be used for a lot of indications. And the sulfonylurea drug classes, including the sulfonylureas as antidiabetics and the sulfonylureas in the form of sulfonamide antibiotics. So, you will notice here that sulfonamides are also drug inhibitors. So, we tend to steer away from using sulfonamide antibiotics because they will have erratic responses. Hindi natin alam if they will function as an inhibitor or an inducer. So what are the common drug inhibitors? Ito, meron na namang mnemonic. Valproic acid and its salt, which is sodium valproate. This is a broad-spectrum anti-seizure medication. Isoniazid, the most potent agent in our therapy of tuberculosis. Cimetidine, a drug that we use to treat hyperacidity. This one is a type 2 histamine 2 receptor antagonist. Ketoconazole, an antifungal that right now is available as a local agent. Locally applied na lang siya. Ni-withdraw na from the market yung systemic ketoconazole, orally taken. Fluconazole, another potent antifungal, systemic. Alcohol intake, but take note, short-term use or acute intake. That is a drug inhibitor. Chloramphenicol, a protein synthesis inhibitor na antibiotic. Erythromycin, another protein synthesis inhibitor na antibiotic, sulfonamides, ciprofloxacin, omeprazole, and metronidazole. So metronidazole again is an antibiotic effective for anaerobes. So what are the generalizations? Most anti-seizure medications are inducers. Okay? Most antibiotics are inhibitors. Okay? So, those are the generalizations. Okay, but please, konti lang naman to, memorize nyo na lang. No? Carbamazepine, rifampicin, chronic alcohol intake, phenytoin, griseofulvin, phenobarbital, and sulfonylureas are inducers. Valproic acid, isoniazid, cimetidine, ketoconazole, fluconazole, alcohol, chloramphenicol, erythromycin, sulfonamides, ciprofloxacin, omeprazole, and metronidazole are drug inhibitors. So let's take a look at some examples that we will commonly encounter in clinical practice. So for example, you have a patient with epilepsy, ibig sabihin palagi siyang nagsi-seizure. No? Epilepsy is a state, not an actual disease, but a manifestation. Seizure is also a manifestation. So, patients who have frequent seizures are termed epileptics. Okay? So, a patient with epilepsy, what is the type of seizure here in this patient? Partial focal seizure. So, partial meaning only a part of the brain is affected. Focal meaning only a part of the brain is affected. Meron siyang seizure of that type, always occurring. That is why, regular, hindi naman regular, but for a long period of time, palagi siyang nagkakaroon ng seizure na to. Kaya siya tinawag na epileptic. A patient with epilepsy, binigay na gamot sa kanya is carbamazepine. So, carbamazepine is an inducer. So, ano na siya, no? Place it at the back of your mind. Carbamazepine is an inducer. So, isipin nyo ngayon, ano bang ginagawa ng isang inducer? He is now admitted at the medical ward for pneumonia. And so, ang binigay na gamot to treat the infection is IV, intravenous or intravascular injection of ampicillin and sulbactam. What is ampicillin? An aminopenicillin, extended spectrum. No? Sulbactam is a suicide inhibitor that will inhibit the action of penicillinase so that the activity of ampicillin is preserved. So, ito yung binibigay sa kanya via IV 4 times a day. Ngayon, isipin nyo, meron siyang enzyme inducer. So, binibigyan siya ng antibiotic that is metabolized by the CYP system. What must be done with his medication regimen? So, isipin nyo, may inducer, merong antibiotic. We can do 2 things. Either increase the dosing of the antibiotic so that the dose of carbamazepine is maintained para makontrol yung seizure niya. Or, for this particular episode of being admitted in the hospital, maybe we can change the carbamazepine into another anti-seizure medication effective for focal seizures but is not associated with enzyme induction. For example, a common agent would be levetiracetam. Okay, we can, for the time being, ngayon lang, bigyan siya ng levetiracetam para hindi mo kailangan i-change ang dose ng Ampisud. Okay? So those are the two things that we can do. Another case, a young adult male admitted at the ward for impaired sensorium. So gising siya, tulog siya, gising siya, tulog siya. Abnormal yung kanyang awareness. No? So, ano palang nangyari sa pasyente? He had a bout of binge drinking alcohol. So, ibig sabihin nun, acute alcohol intake. So, ano nangyari sa kanya? Because of the acute alcohol intake, maybe nagkakaroon na to siya ng mga electrolyte abnormalities or mayroon siyang predisposition to seizure, no? By altering neurotransmitters due to the alcohol. The alcohol alters the activity of the neurotransmitters. Or meron siyang electrolyte abnormality. Maraming pwedeng gawin yung alcohol to predispose the patient to a seizure. Pwede din hypoglycemia, sobrang dami. Ano nangyari? Massive binge drinking. Nagkaroon siya ng 5 seizure episodes, over the past 10 hours. For this, he is given diazepam IV every 4 hours. What must be advised of this regimen? Ano yung pwede nating i-recommend as the clinical pharmacist? We write in the chart. We can write, because this patient has acute alcoholism, the patient is in a state of enzyme inhibition. So the diazepam might not be eliminated in this patient kasi hindi na may metabolize yung diazepam. So what can we do? What can we advise? Decrease the dosing of diazepam because you might have toxic levels of diazepam, and that will produce decreased respiratory drive. Pwedeng hindi huminga ang patient kasi yung brainstem niya inhibited or the muscles are too relaxed. So, in that instance, what will we recommend? Decrease the dose of diazepam and find out the underlying or immediate cause of the seizure. Is there an alcohol related electrolyte imbalance? Pwede na super dehydrated nila and they will have hypernatremia. Mataas yung sodium level sa blood causing the seizure. Is there hypoglycemia? So, you might recommend might want to check electrolytes and give an IV fluid with glucose and electrolytes. For example, D5 water. So you have dextrose in the water together with plain lactated ringers. Sobrang daming electrolytes. Kompleto halos. Okay? To correct the electrolyte abnormality. Okay, so those are 2 examples that we have discussed for enzyme inducers and enzyme inhibitors. So, thank you for listening to this lecture.